Welcome back to the main stage of Virtual Medicine 22. Again, I'm Brennan Spiegel, the chairman of our program here, and along with the rest of our team here at Virtual Medicine, I'm so pleased to introduce our next group of speakers around this theme entitled Avoid the Opioid, VR as a Drug-Free Pain Therapy. Now, realistically, I have to be honest, we can't always just avoid the opioid. There are many people that really require medications for pain, including opioids. And so we have to be thoughtful about not overpromising the opportunity that virtual reality represents for managing pain. But there is an opportunity there. And today we're going to be exploring different ways that virtual reality is being used to help manage pain, to help reduce opioid use where possible, and to help reduce initiation of opioids also where possible. So we're going to be hearing from a wide variety of speakers that represent the sort of breadth and depth of the VR analgesia research initiatives. And first up is also my colleague and friend, Dr. Beth Darnell. Dr. Darnell is an absolute superstar up at Stanford. She is a PhD and associate professor at Stanford University in the Department of Anesthesia, perioperative and pain medicine. She leads large NIH and PCORI funded clinical trials around the management of pain with a particular focus on scalable, generally home-based therapies, particularly cognitive behavioral therapies for the management of pain. She also played a key role in the development of EASE VRX, which is the recently FDA cleared program for management of chronic pain, a program that we also use in our own research here at Cedars-Sinai. So you can read more about her impressive biography online, but to get us started, she'll be discussing virtual reality for scalable, home-based chronic pain management. Thank you so much, Beth, for being on the main stage here at VMed 22.
Hello, I am Dr. Beth Darnell, and I'm an associate professor at Stanford University in the Department of Anesthesiology, Perioperative, and Pain Medicine. I am the director of the Stanford Pain Relief Innovations Lab, and I'm chief science advisor at Applied VR. I am very excited to speak with you today about home-based virtual reality for chronic pain, and I am going to be presenting some exciting results for our randomized controlled clinical trials. Let me share my screen, and there we go. Perfect. This slide just covers some of my disclosures, where I received my grant funding from the NIH, also from PCORI, some important rules that I have, and also books that I have published. And I mentioned that I'm chief science advisor for Applied VR, and that is the company that created EASE VRX, which is the product that I will be speaking about in my talk. So chronic pain is a massive problem in the United States and worldwide. I'm just presenting a statistic that was put forward from the Institute of Medicine in 2011, and they estimated that 100 million Americans are living with ongoing pain of some type. That converts into roughly 1 in 3 adults. And that statistic is common internationally. There is no greater pain prevalence in the United States, though there are treatment differences that we see based on country. Chronic pain is defined as pain that is persisting for 3 to 6 months beyond expected point of healing. And that is a subset of individuals living with ongoing chronic pain. Once pain becomes chronic, it becomes very costly. There's a lot of suffering that is experienced by the individual, by the family, and it is of tremendous societal impact. It remains that pain is primarily treated as a biomedical phenomenon, so that if a person experiences chronic low back pain, they go to their physician or their healthcare provider, they're likely to receive localized treatment based on the site of the pain that they're experiencing. And this is important medical care, of course. But we must stand in some recognition of national calls to apply an integrated treatment approach, one that integrates psychological self-management approaches into the treatment of pain. So beginning in 2011 and over the course of the past decade, we've seen multiple calls from national institutes and agencies for there to be this better integration of psychological and self-management approaches into the treatment of pain. It's what we call the whole person approach to treating pain. And in fact, these calls for better integration really reflect the definition of pain, which is put forward by the International Association for the Study of Pain. Pain is defined as both a noxious sensory and an emotional experience. So these individual factors, psychological factors, are baked into the definition of pain, but of course they're often overlooked or remain untreated within a person's pain care journey. And this really represents a lost opportunity, and it stands in reflection of why whole person pain care is so important. We know that pain is highly complex, and it is influenced by a whole host of individual factors, including the context in which we experience pain, the meaning that we attribute to it, our thoughts, our emotions, our attention, even social factors such as the race differences, the race of the patient relative to the race of the clinician. There's all different factors that combine to influence the degree of pain that a person experiences and that they report. Now, pain is primarily a product of the central nervous system. All pain is processed by the brain and the spinal cord, regardless of where pain is felt in the body and regardless of a person's medical diagnosis. So the central nervous system really being the center for pain processing. And also in the central nervous system is our seat of our psychology, cognition, emotion, and these other factors that are known to influence pain so profoundly. The central nervous system has a capacity, what we call top-down pain processing, so that various factors and influences in the brain, such as the amount of stress we're experiencing, the amount of attention we're giving to our pain, etc., has the capacity to either upregulate or downregulate pain processing and the pain experience of the individual experiencing it. So what we need in light of all of this is, rather than just a biomedical model and a biomedical approach to treating pain, we really need a biopsychosocial approach that characterizes and addresses the needs of the whole person and all of these individual factors that are influenced in the process and experience of pain. So how do we apply this whole person approach? Well, there's a lot of different avenues that are evidence-based and well-studied, but cognitive behavioral therapy for chronic pain has 3 decades of science behind it. This is a treatment that is typically delivered by a highly trained psychologist. It often is delivered over the course of 8, 10, or 12 sessions, usually lasting 1 or 2 hours each. And this can be delivered either individually or in a group setting. This slide displays the various topics that are covered within 8-session cognitive behavioral therapy for chronic pain. This is to be distinguished from general CBT. CBT for chronic pain is very specific. All of the content referencing the pain experience and how pain impacts a person's life. So you'll see that there's these various topics as well as various skills that are acquired over the course of CBT so that a person becomes equipped to better regulate their own pain experience, their own mind, and their own body within the context of pain and within the context of highly challenging medical conditions. How well does it work? Well, I mentioned that there's 3 decades of efficacy science behind CBT. Meta-analyses suggest small to moderate effects for CBT for chronic pain. This one particular study was fascinating because this was a neuroimaging study that characterized the impact of chronic pain on the function and the structure of the central nervous system. So they scanned the brains of individuals at baseline. These were individuals with chronic pain. And then this cohort of individuals went through 11 weeks of CBT, and then the researchers scanned their brains post-treatment. And what they found was that over the course of those 11 weeks, they found that there were substantial volumetric increases in various regions of the brain associated with pain control. So in the course of less than 3 months, the structure of the brain was changed favorably, and this correlated with decreased pain intensity. The effects have been profound enough that the Lancet Evidence Review and Expert Consensus Panel put forward in recent years that CBT should be a first-line treatment for chronic pain. But in fact, we know that our people living with chronic pain very rarely receive CBT as a first-line treatment. And in fact, if it's ever received at all, it can often be a treatment of last resort. In 2016, my colleagues and myself, we quantified these issues to accessing pain psychology or CBT for chronic pain, other evidence-based treatments such as mindfulness-based stress reduction. We surveyed about 2,000 stakeholders, including about 1,000 patients and about 1,000 clinicians. And there's multiple barriers that prevent patients from accessing these evidence-based treatments that have been shown to be effective and that multiple government agencies and institutes have called to be integrated into pain care pathways. Some of these barriers include insurance, travel barriers, copay costs. Therapist availability was a major barrier to patients accessing whole person pain care. And this is where home-based virtual reality becomes an exciting solution because of its scalability and its potential to transcend most of these barriers to pain psychology treatment or to behavioral pain care. So at Applied VR, we studied a first-generation product that involved skills-based treatment, these same types of self-regulatory skills that are important ingredients in CBT for chronic pain within other evidence-based treatments, such as mindfulness-based stress reduction, pain neuroscience education. And so this is a virtual reality treatment where the user places the headset device on their head and they are exposed to a 3D immersive environment. It's highly engaging. It engages visual, auditory, the senses, and the individual basically feels as if they're part of the scene. And this makes for a more engaging environment and a greater degree of learning of the principles that we are teaching in virtual reality treatment for chronic pain, these primarily being self-regulatory skills. So we've studied this first generation product in people with low back pain and fibromyalgia. And this study was particularly rigorous. We didn't just study virtual reality in isolation. We compared the virtual reality treatment to the same content delivered in audio-only format. So we were really able to isolate the immersive effects of virtual reality. So this was a rigorous test, and so people were randomized to either get the headset or the audio-only treatment. And we found equal rates of engagement between these two groups. This was a 21-day program. So for 3 weeks, people engaged with a daily session lasting about 7 minutes in length, and there were 97 people in this study in total. And so what did we find at the end of this study? We found that the virtual reality treatment was superior to audio only. And we found some profound effects, as you can see here, moderate to substantial reductions for pain intensity and also for various indices of pain interference with activity, mood, stress, and sleep. And again, superior to the audio-only treatment. Here, I'm just going to quickly show a couple of data plots. I should mention that this study is open access to anybody who is interested. And here you can see the group differences in pain intensity over time to day 21, which is end of treatment. And then also this other data slide showing the reduction in pain interference with activity over time. You can see the substantial group difference. So next, with these promising results, we aimed to improve on the product. We created an 8-week virtual reality for chronic pain program, more closely mapping on to the duration of treatment and daily skills practice that you see with CBT for chronic pain or mindfulness-based stress reduction, these other gold standard behavioral treatments for chronic pain. And we studied this in a randomized placebo-controlled trial during COVID. And in this study, we compared the 8-week program to a virtual reality sham. And so that sham treatment involved the sham group received the same device, but what they were viewing through their device was a 2-dimensional nature content rather than this interactive skills-based therapeutic program. They just viewed nature scenes with some neutral music. So we were able to control for the novelty of the VR device, and the sham involved no active pain relief skills, unlike the therapeutic product, EaseVRX. So this gives you a schematic of the EaseVRX program. I already mentioned it's 8 weeks. You can see that each week had a theme for the content, and then within each week, there were daily modules, roughly 5 to 7 minutes in length each VR session. And down at the bottom of this slide, you will see the various categories of content that were delivered. So there's a lot of variety involved within the program, but there's consistency in terms of how the information and the modules are being delivered, as well as consistency within each week in terms of the theme that is being targeted. All of these themes fundamentally target important aspects of pain management, and in particular, self-regulatory skills for pain. And you can see that this is the 56-day program. So in total, we had 188 individuals randomized in this trial. And you can see these are adults 18 to 81 years of age. These were people who had at least 6 months duration of chronic low back pain and minimal pain intensity of at least 4 out of 10 for the past month. You can see a couple of visuals here for what people were viewing in their VR headsets. So this slide just displays what some of the content looked like. So here, that first tree, you can see users engaging with nature in the scene. There is a microphone sensor that can detect respiratory rate and breathing patterns of the user. The scene is interactive and responsive based on how the person is breathing, based on their use of the guided relaxation exercises. The scene changes in tandem with the calming response of the individual or the user. So think of it as some interactive biofeedback being reflected to the user for a much more powerful experience and response to the information being delivered. Also in that brief video, you saw some images of the human body. These 3D images being used for an audio educational overlay, and which we're delivering pain education and pain neuroscience education to the user. So they're learning about pain, what they can do about their pain experience. They are learning enhanced self-regulatory skills that have been shown in broader studies to downregulate pain processing and also to improve pain management longitudinally. So this is just a concert diagram which gives the flow of participants through the study. 94 people allocated and randomized and allocated to EaseVRX or therapeutic VR, and 94 allocated to the sham intervention. And I'm going to present our data. So this study also open access and available online. The sample was primarily female. The median age was 51 years, primarily Caucasian, and some college education at minimum, and married. Back pain duration was 5 years or more. There was good distribution across employment status and also household income. So we were able to get a nice snapshot of individuals who are above the US mean for household income and also below as an index of socioeconomic status. And so how did people engage with the program? We found that there's always questions about how engaging a sham intervention is, and we were really pleased to see that there were no differences between the two groups in terms of user engagement. So the sham was effective in terms of maintaining that engagement of people who were assigned to that intervention. In terms of usability, we found that EaseVRX was slightly easier to use than Gmail. This is another important index of really the viability of a treatment in real-world patients. And this is important because, as I mentioned in our previous slide, in this particular study, we did have people with higher levels of education than the general population. And so being able to demonstrate the ease of use of the device is important and continues to be something that we are studying. So how well did EaseVRX work in this study? I want to first present some data slides in which these data are presenting results from baseline all the way to the end of treatment at day 56. And so what you can see here is clinically meaningful differences for reducing pain intensity. Decrease of 41% for EASE-VRX relative to 23% pain reduction for the sham. So it's a highly significant result. Similarly, for pain interference with activity, we see a 48% reduction for the therapeutic VR relative to 32% reduction for sham, also highly significant. Here for sleep, we saw clinically meaningful changes in pain interference with sleep, but the between group difference was not significant. And then here, pain interference with mood, we see a 55% reduction for EASE-VRX and a 37% reduction for the sham, and this reduction was highly significant. And similarly for stress, 57% reduction for EASE-VRX and 37% reduction for the sham, also between group difference highly significant. So this slide just summarizing the between group differences across our 5 primary indices of efficacy, which is pain intensity and pain interference for activity, sleep, mood, and stress, with effect sizes, between group effect sizes being quite large. So most recently, building on these exciting results, we conducted a follow-on where we aim to determine the durability of treatment effects in this study sample. And so we're following the same study sample, but to 3 months post-treatment. So we're collecting data after day 56 to month 1, month 2, and month 3, and we're reporting those results. And I'm just going to give you the quick punchline right off the bat, is that at the end of the 8-week program, we previously had found significant reductions for EASE-VRX across all of these various indices. And then at 3 months, we saw sustained results and sustained superiority for EASE-VRX relative to the sham treatment across all 5 pain indicators. So here, this data slide showing the data for pain intensity, all of these being significant between group differences for pain interference with activity at 3 months, also for pain interference with mood at 3 months, and for pain interference with sleep at 3 months, and then finally for pain interference with stress at 3 months. This publication is, these data were published in Journal of Pain, and they are readily accessible, open access, and online. And then I just want to touch on very quickly for these 3 months post-treatment durability of effects in terms of clinical meaningfulness. We found 65% of EASE-VRX, or what is being rebranded as reliever participants, had moderate clinical meaningful reductions in pain intensity. So about 2/3 of people assigned to the therapeutic VR had moderate clinical benefits, and 46% had substantial clinical reductions for pain intensity. This is for EASE-VRX or for reliever. So conclusions and additional points: home-based virtual reality has been shown to be feasible, and with high satisfaction ratings, we see multidimensional effects and clinically meaningful superiority to sham for the therapeutic VR program. Pain relief skills treatment had direct and lasting effects on pain and pain interference. Virtual reality effects are durable at 3 months. I presented those J-pain data, and we also have in review sustained durability of effects to 6 months post-treatment. And we have taken a look at the impact of socioeconomic status, and our data suggests that the efficacy is invariant to socioeconomic status. In progress, we have a large-scale pragmatic national health economics and outcomes research randomized controlled trial. We're investigating ease VRX reliever in 1,200 people with chronic low back pain in a pragmatic trial to really understand the effectiveness of the device when it's used in real-world patients. And lastly, I just wanted to mention that FDA approval was received for ease VRX and reliever in fall of 2021, and we're excited about commercializing in 2022 and 2023. With that, I'd just like to thank all of my colleagues and co-investigators and scientists and also the developers at Applied VR, and I'd be delighted to take any questions. Thank you.
Well, thank you, Beth, for that invigorating review and overview of your research and for this overview that you've presented to us about the role of virtual reality for managing chronic pain. Now, next up is my friend and colleague here at Cedars-Sinai, Dr. Milton Little, who is an orthopedic surgeon and a trauma surgeon. So he certainly knows a thing or two about pain because he sees a lot of people who are experiencing acute and very severe pain, who have fractured bones, who have had serious traumas. And his role is to help put people back together again, quite literally in some of their most vulnerable moments. And so he's a tremendously skilled surgeon, but he's also interested in what happens after he's done the surgery, when people go to the floor and they're still having pain, discomfort, what can be done at that point to help manage pain in the post-operative setting. So Dr. Little will be talking to us today about just that, about some of the work he's done at Cedars-Sinai and work others have done within the orthopedics realm, using virtual reality as an adjunct to traditional post-operative pain management. The title of Dr. Little's talk is Make No Bones About It, VR Helps Orthopedic Pain. So Milton, thanks so much for being with us here at VMed, and the floor is yours.
Good afternoon. My name is Milton Little, and I'm the Orthopedic Trauma Fellowship Director at Cedars-Sinai. I'd like to thank you for the opportunity to participate in the 2022 Virtual Medicine Conference. Make no bones about it, VR helps orthopedic pain. My disclosures. This study is funded in part by a grant from Applied VR. Additionally, I am a consultant for Globus Medical and DePuy Synthes. Our objectives today are to understand virtual reality technology, to understand the impact of virtual reality on pain management in orthopedic patients, and to recognize future directions of virtual technology. Virtual reality provides an immersive environment which allows a patient to interact with auditory and visual stimuli. And their ability to do so is based on an ability to generate a sense of presence. That presence can determine how much a person is immersed in that environment and interacts with it, and the ways in which they may be impacted by their experiences in that environment. Virtual reality can be utilized in an interactive method or a distraction method. We'll talk about some of the options in which we've seen it utilized. In medical education and training, it's been commonly utilized for many surgical techniques and procedures, which are improved with increased hours of experience. Laparoscopy is an area in which medical students as well as residents have been able to use virtual reality to practice techniques which you may not get the opportunity to practice as frequently in the OR. Additionally, it's been utilized in neurosurgical training as well as in urology training. And in orthopedics, it has been utilized commonly with arthroscopy to increase residents' abilities to participate and work on activities that require a special type of visual spatial interaction. And this is an area which has really gained ground with the changes in the amount of work hours and the number of surgical cases which residents are participating in. From a pain management standpoint, virtual reality has been utilized for patients with who have undergone burn, who have had burn injuries, and patients who have required multiple dressing changes, including pediatric patients. It has also been studied in the use of dental procedures so that patients can improve some of the anxiety associated with that. Here at Cedars, Dr. Spiegel and his group has worked aggressively with the use of virtual reality to decrease narcotic and opioid use in some of their inflammatory bowel disease patients, as well as other hospitalized patients here suffering from pain. So why orthopedics? Well, there's many reasons. In 2001, pain became a fifth vital sign according to the changes in the medical system. With the use of pain as a fifth vital sign, the goal was for patients to have zero pain. And with that, there has been a significant increase in opioid use among patients. What we've learned that patients who take opioids for greater than seven days have a significant increase in the likelihood of an addiction to opioid medications. Additionally, there's been a 49% increase in the number of hospitalizations for patients in relation to opioid use. And that can be anything from constipation to overdose to somnolence and many other things that could lead to very, very poor consequences. Orthopedics itself, we are the third highest prescriber in the country in terms of opioid medications. And that adage, no pain, no gain, doesn't really kind of respond to, our patients don't really respond well to that. You know, oftentimes patients are undergoing multiple procedures or large bony procedures in which there may be a significant amount of pain, and patients are not willing to accept that amount of pain. And so we've developed other methods in which to improve pain control, and those include things such as anti-inflammatory medications, regional anesthesia, and the use of prolonged pain management with some of our pain management colleagues. But those things do have some potential problems. You know, patients who have injuries which may be at risk of compartment syndrome, meaning a increasing pressure in their extremities, are not eligible for use of regional blocks because that numbing may prevent them from noticing compartment syndrome, placing them at risk for losing muscle, amputation, and even death. Some patients are older patients with histories of renal insufficiency, may be non-tolerant of NSAIDs. And then, as we expected, patients with a history of narcotic addiction, you know, we want to avoid the use of opioid medications in them to decrease that risk of dependency. And so how can we find other ways of improving their pain control in the perioperative kind of environment? So here at Cedars, we developed a large randomized control series which evaluated numerous patients admitted with multiple different medical pathologies. And we also included our orthopedic cohort in them so that we can evaluate and assess the ability for virtual reality to improve pain control or at least affect pain control when compared to an audio-visual 2D experience here. Our hypothesis was that virtual reality would lead to a larger decrease in VAS pain scores post-intervention. Additionally, we felt that VR would lead to decreased opioid intake as measured by morphine milliequivalents. And then lastly, we hypothesized that our VR cohort would be more likely to recommend this intervention rather than a 2D experience, which we'll explain in a little bit. So this was a prospective randomized control. Patients were enrolled prior to or on the day of their surgical intervention. These patients were admitted to the hospital either with fractures or admitted for additional injuries which would require orthopedic intervention. In our study groups, for the There was a 3D VR group, and then a 2D group, which utilized a health and wellness channel here at Cedars, which provided them with breathing exercises, calming music, and other wellness techniques in order to improve their in-hospital anxiety. All surgical orthopedic inpatients were eligible. All the patients had to be over the age of 18, and patients who were excluded were patients who were unable to utilize the virtual reality headsets, either with facial injuries or patients with histories of cognitive deficits or seizure disorders. Patients were encouraged to utilize the intervention at least 3 times per day and if necessary for breakthrough pain. We hoped that we utilize the experience or the intervention as their first step prior to utilizing narcotic opioid medication. And pain scores and morphine milligram equivalents were measured as normally measured rather than specifically based on their timing in the day. So we utilized the medical record to calculate or to measure the VAS pain scores previously taken with the patient's vitals at their normal times during the day to avoid falsely trying to alter or falsely recording VAS scores. Their satisfaction of use was recorded after day 2 of the intervention prior to patient's discharge from the hospital. Our primary outcome was change in VAS pain scores 48 hours before and 48 hours after the VR and 2D interventions. Our secondary outcomes were change in MME and likelihood to recommend intervention. We compared pre and post intervention pain scores as well as MME within groups, and a linear mixed model multivariate comparison of the differences in pre and post intervention pain scores as well as MME were measured. A p-value of less than 0.05 was considered significant. These were the pre-intervention variables for our patients. There were 24 patients in the 3D VR group and 30 patients in the 2D group. There was no significant difference in the number of patients, the sex of the patients, or their pre-intervention pain scores or opioid use. These are the operations that were performed on the patients who were participating in the study. Our mean VAS pain scores were recorded 48 hours before and after audiovisual intervention. And you can see that for all of these patients, there was an increase in their pain scores 48 hours after intervention. And remember, for most of these patients, they had undergone a surgical procedure just before they began their use of the intervention. So there is a expected increase in pain scores in these patients after undergoing surgical intervention. And you can see that as their VAS pain scores go up in both cohorts. And as we stated before, there was no significant difference in the change in VAS pain scores between the 2 cohorts. But when we then begin to adjust for age as well as gender for their VAS pain scores and the amount of change, what we noticed was that the 3D VR group had less of an increase in their VAS pain scores when compared to the 2D cohort. In terms of morphine milliequivalent in use for 48 hours before and after, there you can see there was a significant decrease in morphine milliequivalent use, or there was a difference in of MME or morphine milliequivalents in the VR cohort when compared to the 2D cohort, but that was not statistically significant. And even when correcting for age and gender and the adjusted mean difference, there was no significant difference between the two cohorts. And then the last area, which I think this is really critical because I think it's important to recognize that while there may not be a significant improvement in or significant change in their morphine use, there was an improvement in a patient's overall experience and a likelihood to recommend this audiovisual experience. And sometimes that's not necessarily quantifiable. But for us, what we did notice was that for most of our patients, they would be more likely to recommend the 3D experience while in contrast, most of our patients were unlikely to recommend the 2D experience. And there was a significant difference between those two cohorts. So what we saw was that there was no significant difference in mean pre or post-intervention VAS pain scores. And we did see that the VAS increased in both cohorts post-surgery. But when we corrected for age, as well as correcting for sex or gender, there was less of an increase in the VR cohort than there was in the 2D cohort. Additionally, we noticed that our VR cohort were significantly higher and more likely to recommend VR. And what we did note was that there were no adverse reactions to VR or 2D use in either cohorts. So what are the limitations of the study? Well, this was a heterogeneous patient population, right? There were multiple different surgical procedures. And so sometimes it's hard to quantify or compare them completely. Additionally, there's inadequate power. In order to adequately power this study, we would need 120 orthopedic patients. And we're currently in the process of completing that aspect of the study. Our usage tracking was limited. So while we did recommend the patients utilize the VR as well as the audiovisual experience 3 times a day, we had no way of tracking it because of changes in the programming and changes in the computer programming for the VR headsets. So we were unable to see how often the patients utilized it, and we did not measure those numbers. There may be a technology gap. Perhaps older patients may be less willing to utilize it, or there may be something in terms of a patient's presence or ability to generate or develop presence and its impact on their pain, as well as its impact on their use of opioid medications. And then lastly, we are looking at patients who are undergoing surgical procedures. So we are seeing increasing VAS pain scores in all cohorts, and that's secondary to the fact that they are going to undergo a surgical procedure, and that may alter our ability to truly monitor how this is impacting patients. So it may require a longer follow-up for these patients to truly assess their ability to be impacted by this virtual reality experience. So what are some of the future directions, right? So areas that I think are really important are we do many procedures in which we have to realign the bones, and patients with injuries such as this both bone forearm fracture in a young child may benefit from the use of VR to undergo casting and realignment of the bone. Additionally, patients who undergo procedures such as traction pin placements, they may be able to utilize VR in order to decrease some of the anxiety associated with undergoing a bedside procedure. So the idea of utilizing virtual reality as a first line for breakthrough pain is something that I think is really, groundbreaking. Additionally, the idea of utilizing VR for home pain management post-procedure to hopefully decrease the patient's need for narcotic medications could be another area which may really impact the future and decrease the likelihood of things such as opioid addiction. So in conclusion, VR can be utilized for distraction and or interaction, as we've seen both in education as well as management of patients. VR has been showing some promising results on some post-operative pain management in our patients in terms of decreasing that expected kind of jump in pain post-surgical intervention. And then for us, the future uses for VR include future reductions and possible ways in which to help and decrease post-operative depression in polytraumatized patients. I'd like to thank my co-authors for all their hard work on this study. I'd also like to thank Dr. Spiegel for helping us, get involved in this, in the orthopedic department. I know this has been an area where he has really kind of made some really groundbreaking work, and we're just happy to be able to participate. Thank you.
Well, thank you, Milton, for that overview of how virtual reality is being used in orthopedic surgery. And now from one surgeon to another, we're going to move also from the United States to Europe, to the Netherlands, where Professor Harry Van Goor, who is also a surgeon, is going to speak with us on his topic, which is values that matter in VR for pain management. Dr. Van Goor is quite a unique surgeon. Yes, he's a surgeon, but he's interested in a lot more than just operating. He has been the past chair of the Department of Primary and Community Care of the Radboud University Medical Center in the Netherlands. He's published over 350 peer-reviewed papers in a broad field of surgical care. And he's leading several technology tracks in a program called the BBB program, which is quite creative. That stands for fewer bricks, more bites, different behavior. So you can read more about his very innovative and multidisciplinary approach to research there in the Netherlands. And I was recently invited to go join them out there in the Netherlands. There's so much interesting work happening out in the Netherlands, some of which I've highlighted in my opening talk, and you'll be hearing more about it now and throughout the conference. So without further ado, I'd like to introduce Dr. Harry Van Goor to the main stage of VMed 22. Thanks so much for being with us today.
Dear colleague, this is day 7 of the disaster that's happening in the eastern part of Europe. And the title of my talk, Values That Matter, are very timely for this time period. And as a tribute to my Ukraine colleagues with whom we partner in several innovation projects, the majority of my slides is in blue and yellow, the colors of the flag of Ukraine. VR for pain works. We just finished a systematic review and meta-analysis of 122 randomized controlled trials on VR pain management. And the standardized mean difference was 0.65. So this means a median and large effect of VR on self-reported pain by patients. And even in the subgroup of 14 randomized controlled trials in chronic pain management, the SMD was 0.88, a really large effect of VR for chronic pain management. I think this is too good to be true. And when we look more in detail to the studies that are underlying these results, then you can notice that the follow-up period for the VR treatment is max 6 months. And that's with a VR treatment period of 4 to 8 weeks. How is it possible that 4 to 8 weeks of VR treatment can reduce pain in chronic pain conditions for years and years and years. We performed in the first year of the Corona crisis in 2020, a pilot randomized controlled trial of patients with low back pain. And these patients received self-administered, home-based VR for 4 weeks. And this was done in the waiting time before they were able to go to the office of the pain and the anesthesiologist for an intake. At the upper panel, you see the daily worst pain, and in the lower panel, the daily least pain. And as you can see, there is a difference between self-reported pain, between control and intervention. And this starts almost at day 5 to 7 after the start of the VR intervention. But when we look at more general outcomes like mental and physical functioning, we see that there's no difference. There's no difference between control and intervention. There's no difference in time. And there's certainly no difference after 4 months, which means 3 months after ending the VR therapy. In this study, we had a weekly telephone call with these patients. This was mainly because of to solve technical difficulties with the VR at home, but they also gave us very important information on the setting, the time of the year where this trial was taking place. And what patients told us that they experienced less pain during this Corona first months. And when we asked, why do you think you have less pain? They told us that they thought that the pain was not important anymore because of the suffering from many other people from Corona disease. Like I said, this trial was done in a waiting period. And some patients didn't expect anything from the VR because they literally said to us, I will wait for the real treatment, for the definitive treatment. So hope and expectations matter, and the setting in a waiting period is very important. And this is also known from psychological therapy studies, which the waiting time as a setting greatly influences the outcome. I'll present you some quotes of patients. This is about hope. When I started, I was very positive. I hoped so hard it would help. I believed this would be the solution for solving my pain. But it's useless. I'm helpless. The pain will last forever. When we were analyzing the results and also the comments and the experiences patients had during the weekly telephone calls, we remember the three R's, the right therapeutic and the right patient and the right time. But what we also learned is maybe a fourth right, the right expectations. Not only the expectation of a patient, but also the expectation of the provider. A VR classes is not a pill. The action, the work and action of a pill is globally, is about the same in each patient. But this differs greatly from using a VR. And that's because VR technology, but digital technology in general, is mediating the experiences of patients in the real world. So it's between the human subject and the real world experiences. And it has a mediating effect. And this means that this changes the values and how the norms of patients and experiences within these values is changing by the glasses, by the VR content. This also recognizes that values of patients are not stable. There's a value dynamism. So let's look a little bit into this value mediation by technology, how values are differently interpreted by the disease, but also by the interaction between the human, the disease, and also the digital technology, in this case, the VR. So this is about value mediation by VR technology. VR. What are the values that are relevant in VR? And how is VR mediating the values, but also the experiences within these values of patients? In this trial on low back pain, but we also recently finalized a similar study on mediation values in patients with long COVID, and also in patients with acute pain situations. But in this study with low back pain, we did interviews with patients. And this was not the structured interviews we are used to in healthcare. These are structured interviews that are derived from value-sensitive design methods. And we looked at how the VR technology is mediating within values the experiences, and how this is mediating the values and the experiences that the patient has with the disease. So to talk you through this scheme, when we analyzed the outcome of the interviews with patients before they used VR, they told us, and they defined together 6 values, which is health, self-perception, safety, hope, autonomy, and social comfort. And these values were mediated by the disease, by the chronic pain condition, and this is shown in the red squares. So obviously, the chronic low back pain has influence on the value of health and has influence on how within this value there's a feeling of being healthy or not healthy. And in the value of self-perception, the disease determines if you are in a good mood, how your mood is, if you have acceptance of pain. When we did the same structured interviews after 4 weeks of VR treatment, then you see that on almost all norms and experiences by the chronic pain, the VR reality mediates, so to speak, changes or contextualized these norms in chronic pain. And this is resembled by the correspondence of the red squares and the blue dots. So feeling healthy by the chronic disease is mediated, is changed, the experiences in this value of health is mediated and changed by using the virtual reality. But in addition to that, the use of virtual reality also ended up in 4 additional values, which are listed on the lower page, which is privacy, accessibility, sensory comfort, and spatial comfort. These values were not mentioned and defined by the disease before using the VR, but were mentioned and defined after using the VR. And you can see the corresponding experiences and norms within these values. Some quotes. Yes, VR helps me to take control, to take an initiative to deal with my pain. It's autonomy over my health, instead of always just waiting for the pain to come. So this is about autonomy, but also self-perception. It's about VR is mastering and taking control over health and feeling more healthy instead of feeling or reducing the pain. Another, when I'm in pain, I think back. Make the red one scream. This thought helps to deal with the pain. This is self-perception. It means that the patient practices and learns lessons, is educated in the VR world, and practice the lessons learned into the real world. And in my mind, this is more an outcome that gives me the, let's say, positive feeling that this is more durable and more long-standing than when a patient says, I'm not in pain anymore, or it reduces my pain. The third one, I prefer VR therapy over therapy with a medical doctor, as the gamification demands attention instead of passive listening, and more important, does not judge me. The VR is mediating the value, the norms, the experiences within the value of safety, but also over control, and also about social control. Last one, I consciously withdraw myself from my family. I have a place in my office upstairs. It helps me to practice the VR, but I felt guilty not socializing. So this is a negative mediation of VR, because the patient says, with the VR, I'm in my own world, and my family, my relatives are not part of that world. So I cannot take them into what I learn in this world. This is a negative way of mediation. The aim of this study was also to come up with recommendations for design, but actually also recommendations for the evaluation for research. So one of the recommendations regarding health and self-perception was persuasive games, which means that the game should be directed and oriented on changing behavior instead of relieving complaints. VR to reality. Like I said, it's the embodiness in the VR, that means the lessons learned in the VR to practice into reality for a more long-standing result. And then regarding hope and expectations, the therapeutic mutual understanding of how to design, but also how to evaluate, how to use the VR in healthcare is very important. There should be a therapeutic mutual understanding, which means that there should be a shared decision process. Then regarding social comfort, and the recommendation was a socializing VR, which means that patients said, I wanted to have my family within the VR world. Then they understand my complaints, but also my behavior, my health much better. And then I don't have to do it on my own. And very importantly, design uses user-centric approaches. But we learn from our patients, from the wide variety, the different ways of mediating with the technology, that it should be an individual user-centric approach. That doesn't make it much easy for the design, but it's essential to have more an individual user approach than a user or a group-centric approach. And regarding implementation of design and scale up of VR, patients told us they want to have a plug and play VR, and they want to be supported. They want to be served when they are in need for some help. And they don't mind that this should be remotely on a distance, or maybe even in the virtual world themselves. So when you take that into consideration, then automatically when you want to align your design goals with your research goals, your evaluation goals, then the recommendations are completely different than the outcomes that we have now in our research, because most of the outcomes are related to pain. It's either pain, self-reported pain, pain medication, pain-related interference with whatever mood, daily activities. And only some research some studies are now focusing on more participation, societal functioning, etc. This misalignment in design of technology and evaluating the research of the technology is not unique for VR technology. This is a problem of digital technology in general. We recently submitted a paper on that, and it was luckily accepted by the Journal of Medical Internet Research, where we try to make recommendations how to align the design purpose, the design values with the research values, with the research outcomes. And most importantly, how to deal both in design and with research, the mediation, the value dynamism by VR technology. Let's go back to the method we used, the VR content we used in this low back pain trial. This was not directed on pain distraction or whatsoever. As you can see, the method was based on psychological therapeutics like cognitive behavioral therapy, acceptance and commitment therapy, and mindfulness. But most importantly, it was aimed at pain education, at learning the patient to manage, to take control over the pain, but most importantly, to stimulate well-being and functioning. And not for a short period of time, but for the rest of their lives. So actually, this is a lifelong learning method. How can we put this in practice? I would say, if the purpose is psychoeducation, why not have an educational outcome in the research instead of pain? When the purpose is executive functioning, why not have as an outcome daily activities or societal activities? And when the purpose is relaxation, why not have an outcome on well-being instead of reduction of pain or pain scores? We need to rethink our design, our VR pain management, our VR pain, chronic pain management. We need to rethink values and outcomes in the design process of new VR content. And we need to align these with the values and outcomes in the evaluation of new VR content or current VR content. And we constantly have to consider the value mediation by virtual reality. And last but not least, let's think the individual. Not the group, not the median, not the mean, but maybe we have to focus more on the outliers in our trials. Thank you for your attention, and this was not possible without my energetic group, which is the research group VR for Heal, and also in conjunction with that the VR office, which makes it possible to spread the VR not only in our hospital, but also in our region, also at home, and also in other institutes.
Well, thank you, Dr. Van Goor, for sharing that important perspective on values that matter in using virtual reality for chronic pain. Now, next up, we're going to have two speakers from our own team here at Cedars-Sinai Medical Center in Los Angeles. As you know, we have a multidisciplinary virtual reality research program here that includes running several clinical trials. We currently have 3 clinical trials involving virtual reality for pain management that are all funded by various branches of the National Institutes for Health, or NIH, here in the United States. Now, today we're going to be hearing from 2 of our team members, Rebecca Gale and Samuel Eberlein, who are both managing these 3 large, really multi-million-dollar clinical trials, along with a multidisciplinary team here in our group. And they're going to be talking about some of the sort of best practices and lessons learned running these trials, some of the sort of details that are involved in running a multidisciplinary, rather complex trial, particularly focusing on decentralized trials where we can enroll patients from around the world without them having to actually come here in person at Cedars-Sinai. So all of these trials are still ongoing. So if you have patients who might benefit, feel free to let us know here at Cedars and we can talk about their eligibility. But in the meantime, sit back and listen to Rebecca and Sam tell us about their lessons learned running NIH VR pain trials at Cedars-Sinai. Floor is yours, guys.
Good afternoon, everyone. I'm Sam.
And I'm Becca.
And this talk right here, it's going to go out to all the CRCs, the CRAs, the PIs, anyone who wants to run a decentralized health tech trial, but who also want to avoid all those many pitfalls that you'll encounter as you launch and optimize your study. Well, luckily, our team here at CS Core have been conducting these studies for years. And today, Becca and I will try our best to save you from those loss to follow-ups, those unanticipated problems, and all those IRB requests for clarification. So just some quick background. Our typical study is usually a VR versus VR versus VR randomized controlled trial. We have our sugar pill, our sham VR, and that's functionally supposed to mimic watching television in a dark room. You'll put on the headset, but when you enter each video, it's a black void all around and a small rectangle showing some generic nature videos. Well, our middle arm, that's our immersive distractive VR, and that is 360-degree video, normally types of things that are recorded on a tripod in nature. And the idea is that does that extra dimension of immersion and distraction better distract from pain than that placebo? Because, you know, if it does, then we can just ship patients with pain a Oculus 2 headset, tell them to install the YouTube app, and we're good to go. Finally, we have that immersive skills-based VR program. So not only does that have a similar array of 360-degree distraction videos, but there are also an educational component, you know, teaching about the origins of pain. There are some dynamic breathing exercises, as well as some attention building games. And there's even a couple games where you shoot teddy bears with snowballs. And the whole idea here with our active intervention is not only does this extra level of variety and immersion offer a supreme distraction from pain over the other two, but also can we use the headset as a tool to educate our participants on how they can manage pain while they're not wearing the headset, since naturally it's not necessarily like a drug where you take it and it lasts for 12 hours. You may only get the effect while you wear it. So we're really investigating that aspect of it. We also have a third study that's a comparative effectiveness trial, where instead of comparing that active intervention, that same active intervention, to the other 2 VR arms, there is a 2D mHealth mobile health pain management program accessed through a browser, either through your computer, your phone, tablet. And they have a little bit of a different variety in the skills they teach, but that's another type of study that we're running. As far as using the interventions go, normally we'll just give individuals the headset and let them use it at their discretion. We like to recommend a baseline 15 minutes per day at least, try to work into their daily routine. But otherwise, it's really up to them when and how they use the headset. It's designed usually around a 1 to 2 month program, so kind of ignore the x-axis since it can change per study, but there's that treatment period where they go through that predetermined sequence of videos, and then afterwards they are welcome to continue using the headset if they're finding that it's helpful. All the while, we are recording some patient-reported outcomes through a REDCap server and some emailed surveys, and we also give everyone who wants one, we loan them that Fitbit as well, and we can measure their heart rate while they're wearing the headset, the steps per day. If those go up throughout the study, maybe that means they're feeling better, doing some more activities. And finally, we heard some pretty interesting sleep findings from our preliminary VR trials that we ran before, the 3 mentioned in this presentation. So we want to measure sleep as well. Our study flow, it's ideal for the time of COVID in that it requires no in-person contact between the coordinators and the participants. Everything is done fully remotely, from the call to the consent to the study procedures themselves. You can see here a little more friendly, patient-friendly version. We usually start off identifying patients, sending them an email with some information and a flyer. Whether or not they respond to that email will eventually follow up with a informational phone call, and hopefully if everyone's eligible and interested, that will inform consent. One thing that is interesting about our studies is that we have a screener week. We ask individuals to complete 7 days of surveys, and that will allow us to know that the person we're sending a headset to is actually going to be able to complete the study procedures, because if they can't provide us data, it's sort of a wash. After that point, and they completed these 80% of surveys, we randomize them, we deliver their intervention. There's a protocolized phone call where we discuss how to use the intervention and discuss the active study procedures. And after there, it's usually on autopilot. They're using the device for 90 days and filling out surveys as they are sent them. So Becca and I thought it would be best to break our study processes into 5 major categories and then tell you all some of the problems we run into, as well as some of the solutions we found. So Becca, take it away.
All right, so the first challenge that you may run into is one that is certainly not unique to remote trials, but it is one that forces you to get creative during a trial, and that is recruiting participants. So the framework and engagement strategies required for remote trials are nuanced, and we'll start by going over how we recruit remotely, even when recruiting locally. So for our VR study focusing on chronic back pain, we have multiple local and Cedars-Sinai affiliated recruitment sites. You can see on this map of the Cedars-Sinai campus and surrounding area here in LA, we have 4 main sites and clinics that we recruit from. We also search the medical record for participants based on various inclusion and exclusion criteria, mainly using ICD-10 codes. And that is through a program called Deep6. Now, our goal is to make referring participants as easy as possible for our providers, since they're incredibly busy. But we also know that they are our best source of eligible participants. So originally we had it set up as a one-click process, adding their patient to a shared Epic list, which the study team monitors for new additions to then call and hopefully consent potentially eligible patients. But what happens if the provider sees the perfect candidate and forgets to click a button? Well, nowadays we have also started to identify any and all potentially eligible patients that our provider partners see on their schedule, and we actually alert the physician ahead of time that we intend to call their patient to pitch one of our studies. So what you're looking at here is also something we do to help and encourage our providers to continue their recruitment efforts. This is a chart that we circulate among our providers to foster some healthy competition and really keep people updated on the number of participants they've referred. You'll also notice this vertical line at the 20 participant mark. So if a provider refers 20 individuals who actually enroll in the study, then the provider becomes eligible for authorship for a manuscript. So that is also one way we encourage providers to promote recruitment. So once we do have our interested participants, there is of course the issue of consenting. So because these types of VR trials have been deemed minimal risk, we are able to actually consent remotely using a combination of phone calls and emailed consent forms. So we use REDCap for our data collection, and we have set up a framework that allows us to email the consent form to the participant after a coordinator has conducted a consenting phone call and this person has confirmed that they are in fact interested and willing to participate. So the great part about REDCap and this framework is that the consent form automatically triggers the 7 days of surveys for the screener week that Sam mentioned previously. So we don't have to worry about sending any surveys. Once the participant's signature field and the date of the signature field are complete, they will automatically receive their first survey 24 hours after that. And then in the following 24 hours, they will receive their next survey automatically, so on and so forth for the 7 days of the screener week. So now I will hand it back to Sam for our.
Thanks, Becca. So the second challenge is just in the logistics of running a remote trial, my bread and butter. So as far as packaging and sending devices go, you can see here that first and foremost, we want to get it to the patient efficiently, and we want it to look really nice. We took everything into our perfectly fit L2 square and deep FedEx boxes, and we ensure that the headset and all the accessories are wrapped up and they look brand spanking new, because some of them, they're repurposed. And so the places your headsets will go, you can see on this map, 16 states in all 4 corners of the continental United States. And below that, you can sort of see over time the cumulative patients provided by each source. We have really reliable recruitment from our partner physicians, especially our pain clinic. We use the cohort builder at first, but you can see around August, it really trails off because it's just honestly so much easier to recruit and convert a prospective individual who was referred by their doctor over that phone call from a medical record found patient. And we rarely get participants from clinicaltrials.gov, and that's where the others come into play, some strategies on how to find patients outside the CDERS system. More on that later. But some of the problems with shipping, everything's usually by default a 2-day delivery, but sometimes 2 days can take 8. For example, one package that was supposed to just be an hour's drive away into the valley, it went all the way up to Washington, took a stop down in Oregon before finally getting back to Los Angeles, like I said, 8 days later. So what do you do in the scenario as a recorder? Are you going to keep copy pasting tracking numbers on the FedEx website until you see a delivery? That's not really going to be reliable. Are you going to wait for the patient to call you when it arrives? Not all of them are going to do so. And also, you could set up text alerts, email alerts, but you're going to have a lot of packages ongoing. You're going to be getting a lot of alerts at each time. We've just found that that's infeasible. So what we did was, because in an ideal scenario, you want to begin data capture the moment your participant starts to use the intervention. So we actually devised a system to capture package delivery within an hour of it taking place. You can see here a sample log that we create and code out. So every hour, our code pulls not only the REDCap survey data and reformatting it for Tableau, more on that later, but we also scrape the FedEx site for all of our current shipments. In real time, we can see packages that are pending pickup, in transit, delivered, or unfortunately, sometimes delayed. And we like to capture and kick off our VR studies. We want to capture that initial reaction to the virtual reality, or for the unlucky 1 in 3 to the sort of placebo virtual reality. And so our go-to surveys also measure initial simulator sickness as well as presence. How immersed did you feel? And we want to be sure we're capturing that for the very first time someone put the headset on. And so it's just all the more important to get the headsets, get that phone call placed right when the delivery takes place. And not only are we tracking those outgoing deliveries, but we're also tracking the incoming deliveries, because naturally, at the end of the study, when we're asking someone to return their $300 VR headset in return for a $175 Amazon gift card, it can take some schlepping. So unless you want your device to be the payment, which is perfectly reasonable, we did that in the past with TENS units, you're going to have to get a lot of headsets coming back to you, and you're going to have to do a lot of cleaning because, like I said before, you want to send them out, making them look brand spanking new. So we've got coordinators who tackle that when they pile up. And we've also created a decontamination protocol, which especially was important to us during the midst of the initial pandemic when we weren't too sure how the virus would be spreading possibly through our study devices. So we have a protocol where we wipe almost everything down with germicidal wipes, saving the lenses for some less harsh alcohol-based wipes. We even put it into a specially designed UV light box specifically designed to flash the headset all over with UV light. And then we also have put the headset sort of in a 3-day quarantine as well after that. We also have a little printout when we send out a repurposed headset to a new patient that we explain this procedure to them, peace of mind, right? And some things in this whole delivery process, they'll never make sense, right? For example, when we were sending out TENS units, sometimes in one case, it just got completely obliterated en route, had to send another. Other cases, for whatever reason, we ask for the headset, the chargers, everything back at the end of the study. People just send us random cell phone chargers. It makes no sense. We can't use them in our studies, and it happens shockingly often. So that's another thing to keep in mind. So I'm going to kick it off back to Becca for challenge number 3.
So challenge number 3 is remote onboarding. So remote onboarding to the study device and the study itself poses all kinds of predictable and unpredictable challenges because we conduct the onboarding process over the phone, which means essentially that both you, the coordinator, and the participant are wearing a blindfold effectively while you are asking the participant to turn on the headset, to wear the headset, and actually practice navigating through the content. Now, you may not always have the most technically literate population, so we have developed a few suggestions for how to make the onboarding process as smooth as possible. But first things first, we really cannot overstate the importance of knowing your intervention. Not only do you have to be able to walk the participant through the process, but you also have to be able to answer questions about what the participant might be seeing without actually seeing their screen yourself. For staff, familiarizing yourself with the intervention is important. Take it home for the weekend, practice onboarding your colleagues, whatever you have to do to make sure you know the intervention inside and out. For participants, we have created a simplified user manual that they receive with their study materials to kind of help familiarize them and facilitate the onboarding process. This manual in particular highlights only the features that participants will need during the study, nothing more, nothing less. We did have an original manual that had much more information, but we found that contained way too much information. So a simplified version has really been helpful to streamline the process. Other resources that we have for our participants include this FAQ webpage that you see here. It lists answers to very common questions. And of course, participants are always welcome to contact study team members. But we did find that Sam and I were answering many of the same questions multiple times a day. So we now have this website that we direct participants to, and we let them know about it during our onboarding call and in study-related emails. But I think both Sam and I have found that it has significantly reduced the call volume that we receive. And then lastly, and maybe most importantly, we always encourage participants to put us on speakerphone at the beginning of the onboarding phone call. This is because it took us a few onboarding calls to realize that people were trying to use and wear the headset while simultaneously holding the phone to their ear, which obviously introduces additional challenges. So we'll go back to Sam for our 4th problem.
So naturally, now they have the intervention, but now we want to start capturing data over the 2 to 3 months of the study, as well as keeping people engaged. You can remember from that diagram before our study procedures, but let's just take you guys straight to the REDCap default dashboard. You can see almost like a timeline per participant of all the surveys that they're expected to complete. You'll notice there's some white circles, and those are very vague because they don't distinguish the difference between a survey that's not yet been sent or a survey that's been missed. So along with that hourly tracking information, we're going through and refreshing the survey data as well. And so you can see here that there is a version of that has some extra features that we built into Tableau. You can see boxed out where we had 2 of those vague white circles. You can see this was a case where someone had missed 2 survey weeks in a row. One of those is red and marked need to call because it's been 1 week since that first survey was sent, and now we have overlapping surveys. Similarly, moving down left on that same individual, you can see that there were a couple of partial incompletes on the left-hand REDCap view, but we can even distinguish that the first of those 2 was a survey that was missing our primary endpoint, the promised pain interference. So that would elucidate when we make our phone call that we would tell this individual, hey, this is a particularly important survey, very few questions. If you can please go back and fix whatever error, whatever missing question was happening. At the same time, we may find that a form is incomplete because there was just a data sort of mismatch error. For example, in one survey where someone was asked to provide a number of months, they gave us the answer no. And although that may sometimes be a true, false, 1-0 type of situation, not in this case. So we would have to go back, call the patient, hey, can you enter an integer? And it may take us on the study staff to go back into the project and data lock that field to an integer if it wasn't already. There's also the ability, like we said, if we're missing that primary endpoint response, that wasn't something we originally coded. We went a whole year where that just showed up as an incomplete or a missing survey, maybe call about it. So that first year of the study, we missed 23 of these cases. That's a very important survey for us to collect. But ever since we started coding it and color coding it and pinpointing it, we were able to only miss 2 going forward. On the right-hand side, because not everyone's going to log on to Tableau with their credentials and then navigate to the dashboard, we also build in printing out each hour under the tracking information, just who needs to be called and why. Other reasons you might have issues with compliance, maybe people just lose the original survey link. So REDCap does allow you to enable reminders. It's an optional feature. It shouldn't be optional. As long as you're not doing daily recall where the reminders would interfere with a subsequent new survey, which is why we don't send them the second week when they'd have a new survey. We like to send 3 across that very first week, every other day, just to make sure people, maybe you missed the link and here it is again. You may also just want to offer them cash. That's always a great option that we use, every day. In our studies, we use gift cards, gift card, cash is king, but so are gift cards too, right? And so we want to motivate someone, maybe if they're not filling out their surveys, well, here you go. Here's a schedule of all the surveys ahead of you. Here's the one you've missed. And at each milestone, here's the number of surveys that you needed to complete. And hopefully if there was just one survey missing, or maybe even they would want to go for a perfect completion as well, we can get those extra responses and try to maximize the return on our data. So I'm going to throw it back to Becca for our final 5th challenge.
All right, so challenge number 5 is expanding recruitment, right? So we started this list of challenges by discussing recruiting locally, but remotely. And so now we want to discuss what happens when your local well of participants runs dry, providers are maybe no longer engaged, or maybe you're dealing with something less common than one of our chronic lower back pain studies, and you simply need a larger pool of eligible participants to draw from. So you'll recognize this slide from the beginning of the presentation, but you'll see that we have added some sites that we work with in our studies. This not only helps us reach our sample size goals to have these outside sites, but we also just get a more diverse sample because we're recruiting from across the country. So we also utilize reliance agreements to bring in other academic medical centers and recruitment sites on board to refer participants to our studies. Lastly, we do have our studies listed on clinicaltrials.gov, but as you can see here, that is not necessarily always the best source of participants. So we really do recommend some of these other strategies and not relying on clinicaltrials.gov and assuming interested participants will find you and come to you that way. So we do have informational flyers also around the medical center for our study, but we also send them to other sites and clinics to display in waiting rooms and exam rooms. But most recently, we've added this QR code that you see here, and we've added to our flyers to increase recruitment. And the QR code links to our virtual medicine website and all of our current trials. So interested individuals who choose to read more about the study can do so. But what we're most excited about is that they can also click on this Am I Eligible button. So when a participant selects Am I Eligible, in this case for our GI cancer study, they're asked a series of eligibility questions to determine their preliminary eligibility so that we make sure they are most likely going to be eligible. If participants are actually not CEDARS patients, they are able to click through to a form complete with a letter to their treating provider. And the provider can then confirm the participant is eligible. And then, and this is actually very important, it's actually up to the participant to return the form to us, typically via email. We have found that this is the best system to remove the possibility of any HIPAA violations. And it also allows us to recruit from other health systems without data sharing agreements, which often involve the IRB and can be very time intensive. But we also, of course, want to make sure our recruitment is equitable and include prospective participants that do not have the means to see a regular physician or to scan and email us a signed form. So, for example, we have partnered with a local community clinic and created a condensed physician form and have purchased a physical drop box to place on site where patients can submit their forms. So obviously this has been a ton of information, but in terms of our key takeaways when conducting a remote trial and what Sam and I have learned from doing so here at CS Core, first and foremost, we have seen that remote trials have proven successful during COVID and during the pandemic. Additionally, cohort builders can really expedite recruitment at a time when participants might not be seeing their clinicians. We actually saw this at the beginning of the pandemic. People stopped coming in for some more routine visits, but we were able to continue recruiting because we had access to those virtual and digital cohort builders. Additionally, the use of web-based platforms allows for optimal remote monitoring. So the dashboards that you saw when Sam was speaking, that really allows us to monitor our participants and make sure we are collecting the information that we need for our study. It is also critical to run a tight ship. You know, we joke often that our lab is actually also a shipping station, but in some ways that's very true. And having these automated processes really, really helps in the logistics that come with running remote trials. And lastly, finding ways to engage patients outside of the clinical environment has been incredibly important as we expand recruitment and continue to add the number of studies that we are working on.
Yeah, so of course, last but not least, we want to thank all of our team here at CS Core. You know, Becca and I, we manage the 3 studies, but there's a lot of blood, sweat, and tears, a ton of recruitment phone calls, a ton of technical support calls, and we couldn't do it without the team over here at Cedars. And it's not only our team locally running the studies, but that initial recruitment side as well, and the patient outreach, the grantsmanship. I want to personally thank Tom Norris, our sort of patient advocate, who does a lot of work with us, quality control across all of our survey databases before we launch. He makes sure that all of our call scripts and FAQs will take into account the most difficult patient, and I can't thank him enough for his help. But of course, there's Josh, our CRC, there's the docs who help, you know, run the studies. I see Doctors Irwin Hendafar from the cancer study. I see Soyoung and Murad, our biostatisticians, Dr. Jeff Curtis, and Dr. Ashragi from the rural study. Of course, Omer Laron, who's new to the team and building these programs. And, you know, we couldn't do it without all of you guys, and we really appreciate it. And thank you all so much.
Well, thank you, Sam and Becca, for sharing your work with us today and teaching us the nitty-gritty of what it takes to run a virtual reality clinical trial, a decentralized trial where we're shipping equipment to people's homes. So those of you that are interested in doing this sort of work or may have your own protocols ongoing, feel free to reach out to us at Cedars-Sinai if you have questions or want to learn more about how we do it. We also publish all of our research online on our website, virtualmedicine.org, including we publish our own protocols on that website. So you can check it out for more information. Again, thank you so much, Becca and Sam, for sharing your expertise with us. There's really very few people around the world now who do the kind of work that Becca and Sam have been doing for us here at Cedars-Sinai. And I want to thank all the speakers in this session, Avoid the Opioid. We've learned a lot about the opportunities of using virtual reality to help augment traditional medical therapies for pain management. So with that, we're going to take a break and recommend you all head over again to our virtual exhibit hall. We have such a wide range of hardware and software solutions, including software for pain management, as we've been talking about today. Some of the software that you saw in the last session is on display and being exhibited in the virtual exhibit hall. Take a look, meet with the exhibitors, meet with the representatives from the different companies, learn about what they have. There's a lot of opportunities to explore, give you ideas. Check it out, and we will be back here on the main stage at 1:40 p.m. Pacific time. Thanks so much, and again, I hope you are enjoying the conference.
you.